Treatment. As with any disease, early detection is the key to successful treatment. The treatment is personalized depending on the stage of infection. The treatment options may include non-surgical therapy, consisting primarily of scaling and root planning. The primary objective of initial periodontal therapy is to alter the subgingival bacterial profile from one associated with disease, gram-negative anaerobic bacteria, to one associated with health, gram-positive aerobic bacteria. An additional objective is to decontaminate root surfaces that have been exposed to the pathogenic bacteria within the periodontal pocket of calcified bacterial plaque deposits and absorb bacterial products, the lipopolysaccharides and endotoxins we talked about earlier. Surgical therapy, consisting primarily of pocket elimination surgery, either by resection or regeneration. Systemic antibiotics, often used as adjuncts to surgical and non-surgical treatment. They are very rarely used as standalone treatment. Host-modulating antibiotics, Periostat being an example. And Periostat is a doxycycline, which is a low-dose doxycycline, usually given at 20 milligrams of BID. It inhibits collagenase, thus helping to prevent the breakdown of collagen in the periodontal tissues. Locally applied antimicrobials, examples of which include Arrestin, Atrodox, Periochip, Acticite. These will be placed in the pocket to reduce or hopefully eliminate the bacterial load. Arrestin is a 1% minocycline. Atrodox is 10% doxycycline. Periochip is chlorhexidine gluconate, and Acticite is 25% tetracycline. We could also include laser therapy in this list. In-office blood tests. In our office, we routinely perform 3 simple blood tests. All the tests are FDA approved and are done with a simple finger stick. When indicated, we take a full panel cholesterol test. Almost everyone is familiar with what this test is. In our office, we use it only as a screening tool. We prefer not to make any diagnosis based on any test we take. However, when indicated, we do refer the patient to their physician for follow-up testing. The numbers we prefer to see for total cholesterol is less than 200. LDL, or the so-called bad cholesterol, less than 100 is optimal. Triglycerides, less than 150 is normal. HDL, or the so-called good cholesterol, greater than 40 or greater than 60 is optimal. Diabetes risk assessment test. The instant glucose is intended for rapid, early identification of abnormal fasting blood glucose. It provides a preliminary screening using a finger stick. Any abnormal results, and that is usually if the glucose value is 75 milligrams per deciliter or higher, are confirmed with laboratory testing. The lab hemoglobin A1C, also known as HbA1c, gives a picture of your average blood glucose control for the past 2 to 3 months. Hemoglobin is found inside red blood cells. Its job is to carry oxygen from the lungs to all the cells of the body. When you have uncontrolled diabetes, you have too much sugar in your bloodstream. This extra glucose enters your red blood cells and binds with hemoglobin. The more sugar in the blood, the more hemoglobin gets glycated. We prefer the percentage to be less than 6 for non-diabetics. HSCRP, or high sensitivity C-reactive protein test. As we stated earlier, CRP is a blood marker for inflammation and cardiovascular disease. When periodontal or gum disease is present, the inflammation in the mouth can stimulate the release of C-reactive proteins, and studies show that indeed patients with periodontal disease have elevated CRP levels and are therefore at an elevated risk of cardiovascular disease. The New England Journal of Medicine has stated that CRP is a stronger indicator of a future heart attack and stroke than cholesterol. This is evidenced by the fact that 50% of people who have a heart attack and stroke have normal cholesterol. In this next slide, we see that if the CRP is less than 1 milligram per liter, the relative risk of a future cardiovascular event is low. If the CRP is between 1 to 3, we have a moderate risk. And if CRP is greater than 3 milligrams per liter, we are at a high risk. This graph is taken from the research done by Dr. Paul Ritker, who is the director of the Center of Cardiovascular Disease Prevention at the Brigham and Women's Hospital. Examples of CRP elevation. This is a partial list of all those conditions that could elevate CRP levels. As we go down the list, we see urinary tract infections and rheumatoid arthritis, Crohn's disease. We have Hodgkin's lymphoma, which we touched on, colon cancer, prostate cancer, lung cancer. Diabetes, certainly, predisposition to heart attacks and stroke. You can see that the list is long, but again, it's a partial list based on some of the research. Conclusion. The most common chronic infection in this country is periodontal disease. In general, there is an increased awareness from healthcare providers and the general population, thanks in part to the media, of the role that inflammation plays in systemic conditions. The fields of dentistry and medicine have traditionally been worlds apart. But in light of the growing evidence pointing to the links between oral and whole body health, this separation of discipline is slowly beginning to change. As dental professionals, we have a responsibility to identify and treat periodontal disease for every patient at every visit. One of the most important differences between periodontal disease and other systemic conditions is that periodontal disease has a known cause. We know the etiology, and it is quite treatable. This fact alone makes it important to treat this condition, regardless of whether it might contribute to other serious illnesses. And although no one should overstate the oral systemic link, no one should underestimate what can happen if it's ignored either. That concludes our presentation. We will now open the lines for any questions you may have.